Welcome to the Solid Tumor Virtual Education Summit, presented by the Massachusetts Medical Society at OMed Live. My name is Dr. Eric Sherman, and you are tuned in to a live session called Head and Neck Squamous Cell Carcinoma, the Importance of Early Detection and Intervention, Pathogenesis, and Treatment Strategy, with Dr. David G. Pfister. Dr. Pfister is the Chief of Head and Neck Oncology and co-leader of the Multidisciplinary Disease Management Team at Memorial Sloan-Kettering Cancer Center, and received his MD from the University of Pennsylvania. Dr. Pfister received Memorial Sloan-Kettering's Willard F. Whitmore Award for Clinical Excellence in 2011. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send your questions anytime during the program through the box in the lower left-hand side of your screen. Dr. Pfister?
Eric, it's a pleasure to be here, and thank you for the kind introduction. Let's get started right away so we have plenty of time for questions. Let me start just by going over my disclosures for this talk. I'm involved with clinical trials supported by AstraZeneca, Boehringer Ingelheim, Genentech, and Novartis. On a data safety monitoring committee for trials by Boehringer Ingelheim, and I'm chair of the Head and Neck Cancer Clinical Practice Guideline Committee for the National Comprehensive Cancer Network. Another issue related disclosures that distinguish during the presentation today between off-label and on-label drug use. As is the case commonly in oncology, off-label drugs are commonly used in the treatment of head and neck squamous cell cancer. Exceptions include methotrexate, cetuximab, either alone or in combination with radiation or drug therapy, and docetaxel is part of the TPF induction regimen. But take cisplatin, for example, which is widely used in the standard management of squamous cell head and neck cancer, for which there's been many randomized trials. Technically, use of cisplatin is off-label. So over the next 50 minutes, in terms of what I'll cover, first is the importance of improving early detection and intervention in patients with head and neck squamous cell cancer. And then the next two bullets I think are related in my mind, to talk about tumor biology and how this impacts on treatment decisions, and then to integrate with that a discussion of prognosis and current therapeutic options in patients with head and neck squamous cell cancer. And then, time permitting, at the end, depending on how many questions you get, briefly touch on future directions in terms of research and agents of interest. So when we talk about head and neck cancer and the primary disease sites, you can think quite broadly of tumors that occur above the collarbones, but when you read a journal article, it's generally limited to or implied that it refers to tumors of the upper digestive tract. So it would include the oral cavity, the pharynx, which includes the nasopharynx, which is behind your nose. Oral pharynx is when you go on the mirror. The hypopharynx, which is adjacent to the voice box, which food passes through on the way to the esophagus. The nasal cavity and paranasal sinuses. This is a very heterogeneous group clinically, prognostically, and therapeutically in terms of how patients present, for example. A tumor of the voice box would commonly present with hoarseness or difficulty swallowing. A tumor in the nasopharynx, otitis media, a lymph node in the neck. And so part of managing head and neck cancer is to appreciate this heterogeneity. Overall, there are over 50,000 cases in the United States each year, a little over 11,000 deaths estimated in 2013, median age around 60. The age-specific incident mortality rates are higher among African American than other ethnic groups. Males predominate. It's strongly associated with tobacco and alcohol, and their relationship as risk factors is generally considered synergistic. And that's sort of the historic, when you look at head and neck cancer studies in the past, this strong connection with tobacco and alcohol use it figures very prominently. But there are a couple settings where viruses are implicated. The Epstein-Barr virus is associated with nasopharynx cancer, and what has really been receiving great attention over the last 5 to 10 years is the role of prior human papillomavirus infection, which is increasingly appreciated as a risk factor for head and neck cancer, particularly tumors of the oropharynx, such as the base of tongue and tonsil. I know that Dr. Cohen spoke before me and talked about some of the issues with human papillomavirus, and I'm going to touch on a couple just to complement what he discussed. When you look at head and neck cancer and the clinical features, sort of the classic historic discussion of tobacco alcohol-related disease is that it's typically 90+% of the time squamous cell cancer or a variant. The tumor presents in a very local regional way. It tends to be a local disease, lymph nodes in the neck. M1 at presentation is uncommon. A bit more common in tumors of the hypopharynx, tumors of the nasopharynx, particularly when there are prominent lymph node involvement. But it's not like other solid tumors where patients presenting with M1 disease is more common. Because of the role of tobacco and alcohol as risk factors, generally these head and neck cancers related to tobacco and alcohol use, that medical comorbidity is quite common. Emphysema, coronary artery disease, liver disease, and so forth. And this was one of a big challenge in terms of historical studies evaluating new therapies in head and neck cancer, because there were tolerance issues. When you look at 5-year survival rates, commonly patients would potentially not live 5 years, but it could commonly be related to other medical problems as opposed to their index cancer. Another issue related to that prior use of tobacco and alcohol is the development of second primary cancers. And you'll see in the literature descriptors like field cancerization, condemned mucosa, because the carcinogens bathe these areas. And so generally, even if you stop smoking and drinking, there's a rate of second cancers somewhere in the vicinity of 3 to 5% a year. And among patients who continue to smoke and drink, that rate would go upward of 5 to 7%. And so again, something that confounded when you look at trying to do evaluations, interpreting data, is this is another area that would potentially impact on endpoints such as survival that would somehow sometimes dilute the impact of therapy being evaluated for the index disease. So this is the classic tobacco alcohol related upper digestive tract cancer. Now in this next slide, in the HPV era, I highlight in red some of these clinical factors and how they are the same, how they may vary compared to head and neck cancer, which is tobacco and alcohol related. Well, with HPV related head and neck cancer, it's still typically squamous cell cancer or variant. But when you get back a pathology report and it gives the descriptor basaloid variant, generally that's a tip-off that it's HPV related. It's and generally in terms of testing on, I believe Dr. Cohen touched on this, is that you can do a FISH for high-risk HPV subtypes, but checking for a P16 level is commonly widely available and another indicator of an HPV-related association. With HPV-related head and neck cancer, it also has a local regional character. But again, something which is not uncommon is that patients will present with kind of bulky necrotic neck nodes with a relatively small primary. M1 disease at presentation is also uncommon. But because the virus is the driver here, commonly these patients are younger, less tobacco and alcohol use, and with that, less medical comorbidity, so less confounding in terms of other medical issues in terms of tolerance of therapy and potentially affecting outcome. Also, recent data as we started to evaluate more detail these therapy for HPV-related cancers have shown that actually the second primary cancer rate seems to be less than it is with tobacco and alcohol-related disease. Now, I know that Dr. Cohen also touched on the what I think is really an important and seminal paper by Ang and colleagues published in the New England Journal of Medicine in 2010, and that highlighting the prognosis being superior to patients who have HPV-related disease versus tobacco alcohol-related disease. And indeed, when you look back over the last 10 years, the initial wave looking at prognosis was really that, well, you're either HPV positive or HPV negative. But we've become more refined with that, and this is, I think, one of the important take-home messages from this paper that Dr. Ang and colleagues published, which was basically combining HPV status along with tobacco use history and also